Okay, we've been sent a case to evaluate the ability for immediate placement here. So again, the first thing I take a look at is we're going to be looking at site number 19. I take a look at this is a great case for OptiGuide. So we have plenty of T. So the next step is what CEREC data do we have? We have more than enough data for CEREC, and we have designed a restoration. In terms of the accuracy of the restoration design, I would like to point out that my preference on immediate placement is not to draw, sorry, in this case, the tooth is broken down, so the restoration is designed pretty close to ideally. Again, I would go ahead and in an ideal world, fix all of these things. Again, that's just me being a little bit more anal. I want to use all this data, have it as accurate as possible. And from here, we can look at the implant and see that we're coming out at the center of the tooth. We're angled pretty well, but there are a few things I do want to take a closer look at in this particular situation. First, let's evaluate two things. One, the implant plan itself, and then we'll come back to whether or not this is a good case for immediate. So let's start with evaluating just the quality of the implant virtual planning in of itself. So here, if we take a look at it, buccolingually we're good, mesiodistally we're pretty good. Bone level, it's questionable. We're right at the furcation, which is our typical starting point for implant planning. One of the things I'm concerned about here, and this gets a little bit into whether or not we would do immediate placement, is I like to mentally visualize where the bone is. So there's our bone. We can see that we have this crater defect right here, which again does concern me. And then we also have this large furcation defect and right here. So this looks like it's more of a chronic infection, something that's been there for a long time. There are certainly a lot of questions on where the bone will settle. So let's just pretend again the bone level position is correct and designed to the furcation. Next, we will take a look at vital structures. We have the nerve way down here. So as we can see, our nerve is right here. So we have room to go longer. Why would I want to go longer? In this particular case, I'm not confident in the apical extension and engagement for primary stability. So certainly I'd go at least that long. This has a potential of giving me more stability. I would possibly even consider going to a 13 millimeter implant, but that does bring our nerve slightly into concern here. But even then, we can see that we're still quite a bit away from our nerve. You can see our nerve there and there. So even a 13 millimeter implant would work. Nerve-wise, whether the patient opens or not, that's a clinical decision that you'll have to make. But I would want that length for stability, for the primary stability. The bigger concern I have with the plan is going to be my occlusal plane. And looking at this, we can see that our occlusal plane is pointed up, and ideally we would like that to be level. Also, our occlusal table looks very good, but our occlusal plane is not so good. So what do I mean by adjusting the occlusal plane? I would probably in this particular case translate my translate my implant. And in doing so, we now have a more level occlusal plane here. And then when we did that, we've now moved the implant over here to the distal. So we'll go ahead and move that back into the center right here, just like so. So now we can see that we are pretty well centered in our tooth there. So in looking at again from the occlusal view, we can see that we're still centered and everything is coming out the screw access. But now we also, and if truthfully we could probably fix that a little bit more like so, and now we have a more accurate occlusal plane that will properly support the occlusal forces of our implant. If anything, we could look at to say that one of the things I also remember, we use the occlusal plane as a guideline. One of the things I want to take a look at here is my emergence just like so. How will that look? How will that be in terms of being able to build that? And again, that looks like a pretty good one. If anything, we could say that this implant needs to move over a little bit, so we probably move it over to be a little bit more centered, and then doing that we'd have to tilt it back, and that would make our occlusal plane slightly off. But in comparison, we can compare our occlusal plane here in the submitted plan. Again, you can see how the teeth are moving at that angle there, and compare that to the modified plan, and we can see again, we can see the difference there. So that's that evaluation. Now, in terms of whether we would do an immediate placement here, honestly, my initial assessment in this particular case is probably that this is really pushing it for immediate placement, and the reason is I see bone loss into the furcation, significant infection and bone loss here. So my question is where is all of this going to settle? Where are we going to have our final healing occur? Just a lot of questions there. So when I see those kind of questions, my initial intention is to plan on doing some grafting, some socket preservation, take the tooth out, doing the grafting, and then coming back and planning the implant after everything is leveled off and at the 4 to 6 month mark after placement. So my particular suggestion in this situation is to extract the tooth, properly socket graft the area, give it a solid 4 to 6 months for bone remodeling, and then come back, take a new scan, new CEREC scan, and then plan your more ideal, more predictable implant. Thank you for submission, and hopefully you found this very helpful.